Hi, I'm Dr. Bill Wyatt, and I'm going to try to talk to you this morning about a very important thing. If you treat young people, and if you treat young people and you have no understanding of what I want to show you here, you can't hardly do the thing right. Now, it's not a real thing that's very difficult, but you need to understand what goes on in a case like this. And so it's something, if you wait until they're 12 or 14 to do this, which a lot of orthodontists and a lot of people doing orthodontics do, the damage can almost never be correctly taken care of. So anyway, we're going to start off with a neat little kid here. He is just a nice little boy, and he has a good vertical height and everything of the facial structure, but he has some functional problems. Now, you can start even earlier on these functional things. You can start when they're just as soon as you can get in there, just for mouth breathing and tongue thrusting and things like this. But you see the child and you have a problem with there. You look at the facial structure here and you see very little. The facial height is good. You know, your chin and under the nose and come across here and up here in his forehead. You know, he's real, got everything going for him here, but you sure don't want to wait till this child is 12 or 14 before you start something. Now, looking at his teeth, you don't see it completely here, but he's got an open bite, and he has a crossbite on both sides of his mouth. I'm going to show you that in looking at his teeth later. He's got a little bit of fullness in the face, but not all that much. And the mouth may be enlarged, or the vertical may be a little bit more than you want, but not very much. Really looks quite good. Now, this is kind of the way the teeth look, though. This is a perfect example of what I want to make sure, if you work on kids, that you understand this. Now, see this crossbite he's got in here, and the bite is open, so he's a tongue thruster. And you can see anybody that's a tongue thruster, they don't bite together with their teeth properly, and they'll pucker up their lower lip when they swallow. And those will be people that are tongue thrusters. You don't even have to look in their mouth, you just watch them swallow, and they'll do the puckering up of the lower lip, and they'll be together like that. Now, if we look at straight on here, let's see, that's not that one, but here, now we're looking more or less straight at the mouth, and you see the crossbite in here too. And you see the opening in the open bite situation. The tongue's pushing out on this and spread these teeth out and close over there. And so that he is a mouth breather, and he breathes over the top of his tongue. If you breathe through your mouth, you have to breathe over the top of the tongue, and the tongue has to be in the lower arch. And the tongue being in the lower arch, look how much wider it is than the upper arch in here, see? And so the upper arch is falling in on both sides, so he has a bilateral crossbite. A lot of times the tongue will be down here and it'll get wider, and the person will hit on the cusp for a while, and then they'll shift their jaw, and so they'll shift the jaw one way or the other. It looks like he's shifted this direction. See, the midline here and the midline up here is different. The crossbite is greater over on the left side than it is on the right side, and the midline is off. And you can just look at the models of this case and tell what they need. Now you need to see the face, and you need to see the height of the lower third of the face. If this is left alone for a long time, the vertical height of the lower third usually gets higher because they don't bite their teeth together properly when they swallow. And so you need to understand that. So if you're working with kids, man, this is something that needs to be done, and you don't want to wait till they're older to start this. And this is something that people have done. Of course, you can't start them until you see them, but then when you see something like this, it needs to be done right away. You don't want to wait on it. All right, on the looking straight at the left side, you can see the crossbite here is worse, and the midline is off to that side to some extent. So anyway, now we look at the model. This is the finished model, by the way, and it was made to make the retainer that we put on while we waited for the permanent teeth to come in. So this model is made a long time before we, let me see. Now here are the present models. We started them in 2000 right here, and you see the crossbite and the crossbite over here and the tongue thrust. We're looking more up on this, and it makes it look higher. If you look more straight on, this wouldn't be quite as high above this, but this looks, shows you the that he has his tongue thrust problem. And I don't show you any treatment in here, but I show you some stuff on the x-rays when we get to the panorexes. Now, if a guy swallows like that, they kind of pull their lower lip, they kind of pull back on it to swallow that way. So these teeth a lot of times are pulled back, but they're not crooked right here on the bottom arch right now. All right. On the side, you can see this crossbite really plain, and it shows a class 2 malocclusion. You see this is the deciduous teeth, and this 6-year molar should be out in here somewhere like that, and it's off about that much. And then you come out here, it's about the same amount. It's class 2. The left side is a little worse, I think, than the right side. Now look at the right side. You can see that it's in a little better situation, not bad. This is deciduous, and this molar here would have to come out about like such and going back, so it's not quite as bad on the right side as it is the left, but it's bad enough. Now let's see, looking at the upper arch now, it's going to be narrow in here, and if you look straight at it, you will see that this is not shaped like the tongue. If the tongue widened this out, this arch would have to go way out like this, you see. And over the lower arch now that it's going inside of the arch. A lot of times, they'll start this way, and then they'll kind of hit on the cusp, and then they'll shift their jaw to one side or the other, and then if you leave them alone, the jaw grows longer on one side, and the condyle and everything is different, and you can correct it, but it's very difficult. to ever get the thing corrected to stay and look like it would have been, or be like it would have been if you had started it early. So as soon as you see the child swallowing wrong and breathing wrong, and this, you get in there and correct the function, then you probably won't develop this arch like that. It's more narrow. Let me go back here now. Jump too far ahead. Now look at the width of the lower arch. You see the tongue is in here all the time. He's breathing over the top of his tongue, and so the tongue stays in here and it pushes these teeth out like that. And the child sometimes will shift the jaw where they have a crossbite on one side and other teeth meet pretty good on the other side. And you wonder why you see so many of these. It's because of mouth breathing, and that is where you have to have the tongue in the bottom part of the arch, and it's going to widen the lower arch out more than the upper arch, and it'll go in a crossbite, either a bilateral or a unilateral crossbite will develop. And if you leave that alone till they're pretty much grown, and or you say they're 14, 12, 14, 10, you get in there as quick as you can. In fact, when you see this, the functional problem, start it then, even if the child is only 3 or 4, as soon as you get to where you can work with them to correct the tongue thrust and correct the mouth breathing problem. So you may have to expand the palate to get airway, but if the child is suffering from just really allergies, it's harder to do than that. Okay, now let's, whoops, I keep jumping ahead. Alright, this is the first panorex that we've got here, and we know what's going on here, so we know we've got to expand this. So this is my drawing of a palatal separator, so we're going to put that in and widen it and work off of these deciduous teeth and widen this thing up so we can get these teeth down in the mouth. And this will, we try to get out over this. Now when you get the upper arch out of here, the lower arch, and you get him breathing correctly, the tongue fits up in here more, not until you kind of get this thing out, and it holds it down there, but they're breathing where the tongue is not pressing out on these teeth right here. And then the lower arch sometimes narrows down, and then you widen the upper arch where it fits over this, and now you just you do this in a two-phase type situation. So you're going to do this early, and then you come back at a later date and finish the case up. So when you start out, you know that you've got what you've got to do with the patient, and you need to explain this to the parents. You're going to do this and do this. We're going to widen the palate, and we're going to kind of correct the width of this deal going over the teeth, and we're going to stop the tongue thrust. Now, try to, if you're working on stopping the tongue thrust, you must get the person breathing right. Now, if they still can't breathe through their nose, they've got to breathe through the mouth, and it's hard to train them to swallow properly if they're breathing wrong. So whatever you have to do to get them breathing correctly, it's really important to do that. Don't go in and try to correct the tongue thrust problem and still have the person chronically breathing through the mouth. It just doesn't work. hardly at all. You can stop some of it, but not much. Okay, now that's something you have to just work out. Now here is the video. This is the second Panorex, I'm sorry, second Panorex. Now I've got the palatal separator in. Now these teeth are banded. I put bands around them and push on this so that carries the roots out and spreads this thing properly and gets it out there. And usually the developing teeth up in here, as you spread this, they move out too with it. It gives you room to bring those teeth in. Let's see what the that's the tongue thrust appliance. I think you know of. We've got several videos showing tongue thrust appliances and how they're made and all this, and how we do the palatal separator here to increase his airway. Let's see. Okay. Now, this is another view, number 3, a little later down the line, and we've expanded that thing and got it way out, and the teeth will be, the upper teeth will fit over the lower teeth when we get through with this. Now, here is the, I guess it's the 4th Panorex that we've taken, and we have widened this out now, and these teeth are on their way in. We can see we got some play here. You need to rotate this tooth and it won't take up as much room. Move this back, and this cuspid can be brought into that space right there. And we'll get this one over here, and this one will come back some, and that gives us more room for the cuspids to come in. The more cuspids are doing pretty good, and we'll have to come back and rotate some and do the finishing part of the orthodontics. Can be started pretty quick as soon as you just got 1 or 2 of these teeth. You're going to have to take it out. If you get in here with your regular braces, you're going to hold this space, and we've got him coming forward here. We've got 12-year molars, and then we have wisdom teeth on this young man. 12-year molars and wisdom teeth. So he's well loaded back in this area, and he may or may not have room for this, depending on how far this jaw goes back and how long it gets. And if he gets enough room, try to bring that wisdom tooth in. It's one of the best chewing positions. Well, it is the best chewing position in the mouth. Okay, let's see. I think that's the end of our Panorexes. We've got these 13 years and 3 months now. And so then it's ready to go in and do the second phase of the orthodontic treatment, or you can wait a little bit longer, but he's 13 and 3 months, and he's still got a bunch of deciduous teeth. And if you didn't do this, you'd wait till these 14 or so before you start to work, and then it would be too late. You would never be able to correct it, especially if they shift to one side and the jaw grows a few years like that, but one side grows longer than the other side, and getting those jaws matched up and everything is a problem. Well, let's see. Now here we've taken the braces off and everything, the palatal separator. We put a wraparound retainer in, and we're waiting to get the teeth out. It gets these deciduous teeth out, and we'll be ready to start the finished treatment. This is just this is not the finished stuff here. I don't think we left this. We're going to equal get this dude down or this one up, one or the other. We're going to work with that, and we've got to do the finishing orthodontic. So this was a two-phase thing. You go in early and do this correction, and then you come back and you just have to touch it up, and correcting it is rather simple. But if you let him mature or go 14 years old without doing that, you got a problem with it. Or as you can see, the upper teeth fit over the lower teeth pretty well. You may, in your finished treatment now, you may want to come back and widen this a little more even to get it out there or bring it in a little more. Looks like you're widening it, and you see this side over here is corrected. So we stop the tongue thrust. You see these teeth closed up in here, and we enlarge the airway here by pushing the tongue in, so we feel pretty sure that we have corrected function on this young man, and that's what is necessary to do. And I wanted to stress this. You need to understand why they shift their jaw if they go out to one side so they can chew a little better and have it, the upper teeth fit over the lower teeth on the other side of the mouth, say the right side over there, and on the left side over here you've got the crossbite. Right now we've got both of them finished, and we're just waiting, or we're ready really to go in and start the second phase of the treatment. And here is the upper arch now. We got to do some rotations, and we're going to take out, or we're waiting on these. Probably we wouldn't start this right now. We'd give it a little more time and let some of these permanent teeth come on up in the mouth, so we'd be having 2 or 3 bicuspids in there before you start the case. Let's see. Now this is 03, and we started in 2000, so we've been in there a couple of years. You go in and do the first phase. I mean, you put the first phase in here, and you tell them what you're going to do exactly, and you charge so much for that, and then you got to vary it. This part in here will be uncertain as to when, and then you start the second phase, and you have to sit down and make a new contract and everything with them to do the second part of this. Usually the combination is a little more than if you just had everything just so and you just did it on one phase. But you don't wait around with this one. It would be a big, you'd never get it corrected properly, orthodontically. Now, let's see. This is the lower arch, which when we got the upper arch out of here, the lower arch kind of came together on its own. So that helped. Now this looks like, let's see, these one here, the cuspid tooth has come in here, and here's the bicuspid coming in. I think this is a real cuspid. He's got 2 baby teeth to lose there. This one's quite close. Now, here is the kid. We finished doing what we had told the parents we were going to do. We got him corrected that far, but he has other problems, and we'll come back and do that in the finished work in the second phase of the work. He's a good little kid, real nice folks, and that's the end of it. I thank you for watching this, and this is important. If you work on children and a pediatric dentist that doesn't understand this, you have to send them in, and it's hard for you to deal with an orthodontist if you just want him to do one or two things like this. If you will learn how to do this yourself, it will be much better for you to do it than it will be for an orthodontist to go back and forth between you two and doing it. You can do that. That's better, certainly better than not doing it. If you let them develop a unilateral crossbite, then their chin's going to be off to one side, and you can't hardly get the arches coordinated after that. So anyway, I hope you take this seriously, and if you're going to work with kids, you need to understand this, where they push out and form these crossbites.